Welcome to mmlearn.org, a program of Morningside Ministries and Ask the Geriatrician series. We want to make sure that this program answers all your questions, so if you do want to ask a question or make a comment during any part of the presentation, you can click on the Ask bubble above the video, and you can see where the arrow points to that, and you can make a comment, and you're also able to phone in or text your question to us at 210-889-1285. And if you're watching this on demand later, you can still use the bubble and send a question to us, and we try to get an answer back to you within 72 hours. What do you think? Well, what you think is very important to us. We'd like to make sure that at the end of each program that you watch with us, you always complete a survey. Your feedback is important because it tells us more about the programming that you want to see, the quality that we're giving to you, and also it takes less than 5 minutes and it helps us to obtain further funding to be able to continue to bring these programs to you free. Appreciation is extended to all the foundations and individuals that make these programs available to us. And if you meet with any of these folks, please thank them for us. We do often because we know how important these programs are. To access resources, that means if you'd like to download PowerPoints or if there's anything that we're providing online for you to be able to share with others, there's a little paper clip up in the corner. And if you'll just click on that, it'll open it up for you, and you can download the information and have it and print it right off for yourself or share with others. Just a reminder, please fill out that survey. To request any materials from us at any time, you have that number on your slide here, info@mmlearn.org. Don't hesitate to ask. We have lots to send out to you. And if you'd like to donate to mmlearn, we're always appreciative for that as well. Remember, at the end of this session, you're going to have a question and answer time with Dr. Zayac. And I'm telling you, this is so exciting because talking about the aging eye is something that we've wanted to bring to you for a long time. I had the opportunity to hear this physician talk with us previously. He did such a wonderful job that I'm just so delighted that he could join us at mmlearn.org today. So enjoy and do ask lots of questions and fill out those surveys. Thank you so much.
Good morning. My name is Joe Zayac. I appreciate having you join us this morning. I also would like to thank Morningside Ministries for allowing me to give you this presentation. The presentation is called The Aging Eye. I am an optometrist associated on staff with the Department of Ophthalmology at the University of Texas Health Science Center in San Antonio. In the upper left-hand corner, you'll see two of our eye surgeons performing surgery on an eye. Most eye surgery is performed through an operating microscope. We also train residents in ophthalmology. On the top right, you see a group of our residents. Our clinical practices are located in the Medical Center of San Antonio at 8300 Floyd Curl Drive, and we also have a clinic dedicated to diabetes at 701 South Zarzamora Street. I'd like to start by going over a little bit of ocular anatomy. We'll start from the top. This is an illustration from a famous medical illustrator, Dr. Netter. I've added some extra blocks in there that are associated with aging. Now, as we look from the top down, the way we see light enters the cornea, it passes through the pupil, then through the crystalline lens, and hits the retina in the area called the fovea. The areas I've highlighted that are associated with aging, let's look first at the angle or the trabecular meshwork area. The eye has an angle that forms between the cornea and the iris. If this area becomes crowded, the fluid that's produced in the eye cannot exit and the pressure will build up and cause narrow angle glaucoma. A lot of medications that elderly people take will dilate the pupil as a secondary side effect, and this can cause this angle closure glaucoma. Next, as we go through the pupil, you'll see the lens of the eye. The lens of the eye from birth is clear, but as we get older, it becomes cloudy. When it becomes cloudy enough that light does not pass through and it interferes with vision, it's called a cataract. As the light passes past the lens into the vitreous is a gel at birth and slowly becomes more liquefied with time. At a certain age, it will tend to disconnect and can cause retinal problems. Then light strikes the retina, specifically in the area of the fovea. The fovea is the center of the macula. The fovea has the most important area of the vision, and this is where we get 20/20 vision. Unfortunately, a lot of eye diseases occur in this area. And then as the light hits the retina, it's turned into an electrical impulse and travels down the optic nerve to the brain, where it's interpreted as vision. A lot of patients ask, what is visual acuity when I say I have 20/20? Well, visual acuity is expressed as a fraction. The numerator is the distance at which the patient reads the chart, and it's usually 20 feet. The denominator is the distance at which someone with normal vision reads the same line on the chart. For example, a patient that has 20/60 vision compared to a patient that has 20/20. If you have 20/60 vision, a patient who has 20/20 vision can stand away 60 feet and see the same thing that you're required to see at 20 feet. Most eye charts go up to about 2200 or 2400 vision. So the higher the number on the denominator, the worse the visual acuity. Some people cannot see the big E on the eye chart, so we have them walk forward. And again, the numerator, if they can go up to 10 feet and still see the 2200 letter, we classify that as 10/200 vision. Some people cannot see that well, and so we hold up our fingers and ask them if they can count our fingers. So we might say, yes, they can count fingers at 3 feet. Some people don't have that type of visual acuity. So next, we wave our hand in front of them. And if they can see motion from the hand, we'll say hand motion at 2 feet. Some people can only see light. If they see light, we call that light perception. And those unfortunate individuals who have no light perception, we just call that NLP. Now, just for your information, the government considers legal blindness as the best corrected visual acuity in the better eye of 2200. This is for tax purposes and other individual things that might pertain to you as far as being reimbursed. Also, you can have 20/20 vision, but have a field of vision down to 20 degrees. Let's talk a little bit about refractive errors. Typically, a need for glasses stops changing at about age 20 to 25. If there's a significant change in vision, we might suspect that there might be some pathology and be a little more concerned. But I'd like to go over some of the basic refractive errors. If you are nearsighted, you are myopic. Essentially, the eye is too powerful or too big. So when light enters the cornea and is refracted, it comes to focus in front of the retina and causes the vision to be blurry. This is at a distance. But nearsighted people can see well at near. Most people have this type of correction, or at least 30% of the population. What we have to do is to move the light back, and this is done with minus lenses. The image moves back to the retina by either glasses or contact lenses, or what's very popular now is refractive surgery, referred to as LASIK. As a patient develops cataracts, they usually become more nearsighted. Hyperopia, on the other end, the eye is not powerful enough, so the light focuses behind the retina. If you're less than 40 years old, it really doesn't affect things, depending on the amount of the hyperopia. You usually see clear at distance, and you usually see clear at near. This is a problem for younger people who, especially children that might have 20/20 vision when they're checked at school on the eye chart, but have a significant hyperopia that can lead to other problems. Now, when we reach presbyopia, or around 40 years old, the distance vision and the near vision starts to come more into play. So this correction is compensated for by using plus lenses, so to converge the light to focus on the retina. The other thing that the hyperopic patient can do is accommodate. The crystalline lens inside of the eye can bend. It can focus the light, and that's what happens in children, and sometimes results in crossed eyes. In the adult, when the accommodate, they can lead to eye strain and symptoms with reading. This again can be corrected with glasses, contact lenses, and to a limited extent, refractive surgery. Most people have some degree of astigmatism. Astigmatism just refers to the eye not being perfectly spherical. Analogy is comparing a basketball to a football. The basketball, all of the radii would be the same length. In the football, the vertical radii, in this case, would be steeper than that in the horizontal. We treat this with cylindrical lenses, and there's usually some component of either being nearsighted or farsighted with that. But astigmatism is very common. It's corrected with spectacles, contact lenses, and refractive surgery. Now, presbyopia in itself is Greek for old vision. Somewhere around 38 to 42, the lens inside of the eye starts to stiffen, and we're not able to see things up closer. So you typically see the patient pushing, or the individual pushing the book or reading material farther away. At that distance, the eye does not have to accommodate. The correction for this is reading glasses or bifocals. Now, how do you read your optical prescription? Many people are interested in this. OD means right eye. OS means left eye. The first number, OU means both eyes. The first number is the amount of spherical correction. If you are nearsighted, it will have a negative sign in front of it. If you're farsighted, you'll have a positive sign. The right eye is nearsighted. The left eye, in this case, is farsighted. The second number is the amount of the astigmatism. The third number refers to the alignment of the astigmatism on a scale from 0 to 180 degrees. The add is the power, additional power needed in a bifocal for reading. The number 65 over 62 is an example of what the distance is between the pupils. A lot of my patients now are asking for that dimension so that they can order glasses on the internet. And PAL means progressive addition lenses. That means the no-line bifocals, which are becoming very popular. Now, let's talk about the eye itself. Now, most people don't consider the tears to be a very significant part of the eye, but in fact, it's probably one of the most important parts of the eye. The tear layer is composed of 3 layers: oil, aqueous, and mucin. The aqueous more watery. The components of this tear layer come from the glands in the eyelids. So any dysfunction in the eyelids can cause a breakup in the tear film and lead to ocular surface disease. So extremely important to have a very healthy tear layer. Now, this is an example of an eye that does not have a good tear layer. What you're looking at is a magnified view of the upper lid, part of the eye, and part of the cornea. If you look closely at the eyelid, you can see that there's indentations. You can see little capsules blocking off the oil glands. You can see crust on the eyelids. So here is meibomian and gland dysfunction. So a good tear film is not present. You can see the eye is red. One of the most important things that I can express for you today, if you take home, is keep the eyelids clear and clean for both yourself and those that you take care of. The way we suggest that you do this is when you bathe or shower, take the warm washcloth, put it on the eyelids for a few seconds, then put some dilute baby shampoo on the washcloth and rigorously scrub the eyelid margins. A lot of people are afraid to get close to the eye and afraid that they're going to hurt it or it will sting. If you use the baby shampoo, it doesn't. And one of the most important things you can do for the people that you take care of is make sure they have clean eyelid margins. Here's an individual that did not have that benefit. You can see that the lid margins are thickened, the eyelids, lashes are turned in, the eye is uncomfortable, it's red, and a lot of this could have been avoided had proper lid correction been done. Some other common things that happen to the eyelids. On the left screen, you'll see that this is a hordeolum, or what's called a stye. This is when one of the glands blocks up. The best treatment for this is not medicine or ointments, it's heat. So if you can put warm compresses on the eye 4 or 5 times a day and then massage, if it's on the upper lid, massage from the up down, and try to break open the little gland opening. This needs to be done 4 or 5 times a day. Now, in some situations, it just does not drain, and it turns into a situation on the right-hand side called a chalazion. Here, the oils have solidified, and it's usually not painful at this point, but it can affect vision because it's big enough that it can press on the cornea and induce astigmatism. The only way to take these off if they're big enough is surgically, although the small ones usually we don't worry about, and they usually go away with time. Now here's something that's very concerning. This looks very much like a sty on this individual's upper eyelid, but in fact this is cancer. This is a basal cell carcinoma. It looks very much like a sty in that it's swollen, it's red, but if you look closely you'll see that the margins are pearly and there's a little bit of a crater. This needs immediate attention. It's more prominent in people who are outdoors a lot and people who have fair skin. As we all get older, we just lose the eyelids just get heavy and fall down. It's a cosmetic issue, but more so it's limits our visual field. So a lot of times you'll see the patients will lift up their chins just to see better far away, or have to turn their head quite a bit to drive, especially when looking to the left side. The best correction for this is with surgery, although they do make glasses that have what's called a crutch that will help hold the eyelid up. Ptosis is just normal aging where the eye drops down. Here it's getting fairly low, and you can see that it's almost bisecting the pupil, so this is definitely interfering with the visual field. Now there is a condition that's more serious, and that's when one of the eyelids drop down and you see a difference in the pupil size. So this is called Horner syndrome. It's a combination of a drooping of the eye, of one eyelid, in this case the right eye is drooping down, and a constriction of the pupil. If you look at the pupil, you'll see that the right pupil is smaller than the left pupil. Also, there's sometimes decreased sweating of the face on the same side. This indicates a problem with the sympathetic nervous system, and a sudden onset requires medical attention, as there are some tumors associated with this condition. Myasthenia gravis is also another condition that's often missed until other symptoms show up. Here we have ptosis of the left eyelid. The pupils are of equal size. Certain muscles, such as those that control the eye and eyelid movements, facial expression, chewing, talking, and swallowing, are often, but not always, involved in this disorder. The muscles that control breathing and neck and limb movements may also be affected. Now this condition can be treated with medicine. The most common situation that occurs when the lid margins are not properly cared for, or just with normal aging, is the eyelids will turn in. You can see in both of these cases the upper eyelid has turned in, and the eyelashes are actually scraping against the cornea. This is causing abrasion and extreme discomfort. Surgical management of this is necessary. Many people also have the opposite. In this situation, especially this left eye, the eyelid has drooped out. We make tears in the upper part of the eyelid. As we blink, tears are squeezed across the eye and exit near the nose. In this particular case, the tears cannot go anywhere, and the patient's tears just drop out over his eyelids, making it very uncomfortable, but also increases the risk of infection. Now, the next layer that we'll talk about is the conjunctiva. It's a thin membrane that's attached to the cornea. It goes up around the eyelid and then drops down and connects to the area near the eyelashes and the glands. The part that's next to the eye itself is called the bulbar. The part that makes a little circle is the fornix, and the part attached to the eyelid is called the palpebral area. This is a patient with thyroid disease, so you can see the conjunctiva very well. Thyroid disease in some patients causes the eyes to bulge forward, or we call that exophthalmos. In addition to the thyroid problem, the problem is with the eyes is that these individuals cannot close their eyes well, and the surface of the cornea dries up, causing discomfort that way. Even after the thyroid disease is treated, many patients still retain the exophthalmos, and it's necessary to have surgery to put the eyes back into the orbit at the normal position. Now, if an individual has exophthalmos in only one eye, it can be a serious problem and may indicate a mass behind the eye and requires immediate medical attention. This is a common presentation. People get very upset. They often present after brushing their teeth and say, look in the mirror and see that their eye is full of blood. These are usually, for the most part, benign. The conjunctiva is clear, so during the night you either bumped your eye or strained or some reason, causing a blood vessel to break. And because the conjunctiva is clear, you see the blood, much like a bruise, but our skin has color, you don't see it as well. This is what it will look like on day 1, but day 2 it may look even worse as gravity pulls the blood on down to the lower part of the eye. The best for this is just give it time and to use cool compresses to coagulate the blood. Pink eye is a very common situation. This is conjunctivitis or inflammation of the conjunctiva. The most common cause of conjunctivitis is viral. There are a few cases that are associated with bacteria. These typically have more of a pussy discharge. And then a large percentage of conjunctivitis are related to allergies. Eye drops can be beneficial. A lot of times just time will help. Now here's an individual that had conjunctivitis and was treated with eye drops, and she's had an allergic reaction on her skin. So probably the conjunctivitis would have resolved within a few days, but now she's stuck with this contact dermatitis, which will be very uncomfortable and last for weeks. So it's very important to let your eye doctor or your primary care doctor know if you are allergic to any type of medicine. A serious inflammatory disease affecting the sclera, which is the white of the eye, is often associated with rheumatoid arthritis and other autoimmune diseases. You should remember that pain associated with eye movement is a medical emergency. It is not normal to have pain with any type of eye movement. This is a condition we see commonly in Texas and in the Sun Belt. This is called a pterygium, where excess tissue is growing over the conjunctiva. It's usually more just related to people who are outdoors, particularly those that work in construction. It's not significant in that it's a cosmetic issue, or sometimes the pterygium will grow into the cornea, affecting the vision, and they need to be removed surgically. When we look at the fornix part of the conjunctiva, which is the part in the lower here where you see this brown spot, there should never be pigment in this area of the eye. This patient presented with this pigment, and it was determined that this was a malignant melanoma. Extremely serious situation. This patient saw 2 doctors before coming to us. He had a little sore on his eye, and once it was biopsied, it turned out to be a squamous cell carcinoma, a cancer of with a squamous cell. And consequently, it had invaded into the contents of his eye and around the orbit, so his eye had to be removed as well as the contents of the rest of the eye. Fortunately, his other eye has good vision. But don't take lightly any sores or disruptions around the lids. Very important to keep that in mind. Now let's talk about the cornea. Although the cornea is clear and seems to lack substance, it is actually a highly organized group of cells and proteins. Unlike most tissues in the body, the cornea contains no blood vessels to nourish or protect it against infection. Instead, the cornea receives its nourishment from the tears and the aqueous humor, which is directly behind the chamber. The cornea must remain transparent to refract light properly, and the presence of even small blood vessels can interfere with the process. To see well, all layers of the cornea must be free of any cloudy or opaque areas. Commonly, patients indicate concern about this white ring around the outside of their eyes. This is, for the most part, benign. This is cholesterol that has gathered in the outside of the eye. Many patients think that this is a cataract. It's not a cataract. It's just a line. It will not interfere with vision at all. Now, if we see this in a younger person, 30 or 40 and younger, we make sure that they have their cholesterol checked. But in elderly adults, it's of no concern. By far, the most common problem that we see is the dry eye. Again, we go back to proper lid hygiene. And in these patients, ironically, the eyes tear a lot. And that's because there's a reflex to try to keep the tear film over the eye. And when this reflex happens, they tear too much. So very common. In this one, you see about 6 o'clock position. There's actually a filament of part of the skin growing up. The best way to treat this, and the way we treat it, is first with lid hygiene, and that's the baby scrubs, baby shampoo scrubs. Then secondly, we use non-preserved artificial tears up to 4 or 5 times a day. And then at bedtime, a bland ointment applied to the inside of the lower lids. And this is usually a treatment for life. But again, with good lid hygiene, this can be improved. Some of the medications that our older patients take cause secondary effects in the eye. This is a condition where the cornea has a whorl. It's a pigmentation. And this one is caused by amiodarone, which is a medicine that is used for heart disease. Fortunately, this one does not cause any visual problems. Some of our older patients use different types of makeups. This individual was using actually a silver-based makeup, and over years and years and years it actually gone into her cornea and affected her vision. Most makeups now are regulated by the FDA, and you wouldn't see this situation. Very common in our older population are shingles. And shingles around the eye manifest from the trigeminal nerve, which has a branch that goes into the eye. So if you are giving care to an individual and you see these little vesicles, even 1 or 2, they should be referred immediately to their primary care doctor and started on antiviral oral medication. Usually if that's done, we can avoid other complications. Now what happens on the eye is in the photograph on the left, you get these what called dendrites, or the little opacities, and these can scar and permanently affect vision. The problem is they may reoccur, but we like to see any patient that has shingles to make sure that they don't have any ocular involvement. Herpes simplex is another virus associated with the cold sore, and it can have dendrites on the front of it. These 2 of them, I've used a different type of stain here. On the left, when you see a red stain, and that dendrite is the virus itself. On the right is a larger one, and as these heal, they scar. These patients also will often have recurrences of these, and it can be a very visually disabling condition. Some of us, just with age, develop dystrophy of the cornea. Here you see a lot of white spots in the cornea, and obviously this is going to affect the visual acuity. One of the more common forms of corneal dystrophy is called Fuchs dystrophy. This is a breakdown of the inner layer of the cornea, so that now the aqueous cannot flow back and forth and nourish the cornea, so it turns cloudy, it becomes painful, and affects the vision. These patients require surgery to compensate for this in later stages. Some corneas do not grow smoothly. They tend to point in a condition called keratoconus. So as I mentioned earlier, anytime there's a disruption in the normal collagen fibers of the cornea, they turn opaque. So these individuals have a very serious problem in that they are unable to see well with spectacles and require hard contact lenses, and go on even at sometimes to require corneal transplants as the cone becomes more advanced. We talked a little bit about LASIK surgery. For the most part, LASIK surgery is problem-free and very effective. This patient had not such a good outcome. She had multiple surgical procedures starting from years ago, and the only way this individual can see is, again, with a hard contact lens. But you see the amount of scarring. Again, though, I want to reassure you that this is very unusual. Here's another patient that I saw. They tried to affect the vision by putting a little ring in there to ban the refractive surgery. And you'll see that she also had to require a contact lens to see well. Now, I always put in a spiel about contact lenses. Even though the contact lens may be designated as an extended wear, and that is a contact lens that you can sleep in, I strongly discourage patients from sleeping in their contact lenses. This is a patient that would overwear the contact lenses. This is happened to be a colored contact lens where it changes the color of the iris. Unfortunately, this patient did not take very good care of their cases or their lenses, and this is the other eye. This is from a bacteria that broke into the cornea, and within a matter of 24 to 48 hours, you can lose the cornea with some of these very virulent bacteria. This is a similar type patient from a patient who overwore her contact lenses and had the complications and had to have a corneal transplant. This is like a day or two out after having the corneal transplant. Now, double vision is a serious problem. We call that diplopia. And sudden onset of diplopia should be evaluated by a physician. Even after evaluation, and especially with diabetics, the double vision will often resolve. But in cases where it doesn't, people will wear eye patches. Or what I have been doing for patients is to use a contact lens that blocks the pupil. In this case, that's not the pupil you'll see. That's a large black contact lens so that individual cannot see out of that eye. Unfortunately, this patient had a brain tumor, and adults do not suppress double vision. Children suppress double vision, but unfortunately, they develop amblyopia or the lazy eye. So double vision should be investigated immediately. Now, here's a case that was very interesting. You'd spend more attention looking at things maybe that you shouldn't. But this was a 42-year-old female that presented with the chief complaint of irritation in her left eye for months. Her ocular history was significant for recurrent retinal detachments in her left eye. Her visual acuity in the right eye was good. It was 20/25. In her left eye, she could only see my hand move. Her pressure, intraocular pressure, was measured at 15 millimeters of mercury, which is exactly normal. The left eye was 38, so it was more than twice the normal. So you're thinking that maybe she has a problem with glaucoma, or you see that white band going across the cornea. That might be a problem. But with further investigation, when you ask the patient to look to either side, you see this little knot on the side there. What that is, that's a suture coming out, eroding out. The way they repair retinal detachment, especially in the past, is to put a circling band around the eye and then attach it with sutures. You need to just look, especially these older patients that have had retinal surgery years ago, to make sure that band or those sutures are not eroding. If you can actually see the band, that's a medical emergency, and the patient needs to be referred to a doctor, as these patients can have a serious infection inside of the eyes. Now, let's go to the crystalline lens. So here is a cross-section taken with a microscope. That first band that you see to the left that looks like a C is the cornea. Then the next clear area is the aqueous humor. And then you see the crystalline lens. And it looks similar to like an onion. This particular one is a little bit abnormal in that the anterior part has a little cone to it, which indicates that this patient has Alport syndrome, which is a rare condition. But it's a good photograph to show you where the lens is located, just right behind the iris. Now, unfortunately, some people who don't have insurance or just don't have access to medical care, you can actually see the cataract with the naked eye. In this eye, you can see that white in the center of the pupil is a very, very dense cataract. Needs to come out immediately. This patient would probably have just hand motion vision, if that. On the left side, I have dilated the pupil, and you see this red reflex. So the red reflex bounces off the retina, so you see this black area in the middle of the vision. That's called that's a cataract, so you just see it from the back, and you see how something like that would affect vision. The cataract on the right side may not cause that much vision. It's more on the outside. The center is clearer. So cataracts are very common. And it depends on where the cataract is located and how much it affects the vision. People who take long-term steroids can not only get glaucoma, but they also get a particular type of cataract called a posterior subcapsular cataract. In this eye, if you look in the center, you see that the cataract is in the middle, but it's on the very back surface of this. And this was even with a younger patient that starts to form a cataract. Most of the patients require the steroid, so there's nothing you can do to reverse this. Now, cataracts are removed in an outpatient surgical procedure. It's the most common operation performed in the United States. And what they do is they remove the crystalline lens and replace it with an artificial lens, and you can see the size is compared to a dime. The shape of the eye is measured, the length of the eye is measured, and many times all you need is glasses to read with after you've had cataract surgery, if even that. So it's a very successful surgery. Now, one thing that a lot of your male individuals that you're taking care of may have benign prostatic hyperplasia. There's a medication called Flomax, which is used in this situation. And if you've seen the commercial, it says, tell your eye surgeon if you take Flomax. It's because it makes the iris floppy when they're doing surgery. So in this particular slide on the right, you see that little hooks have been placed in the eye to hold the iris in place while the intraocular lens is instilled. So it's very important that if there's a male individual that's had prostate problems and certain medications, that they let the eye surgeon know. Here's a situation on the left where it was not known, and you can see that the iris between the 12 and 9 o'clock position is torn, and so the cataract was removed successfully. The patient has good vision, but because of this extra pupil and this extra light that comes in, the patient is very sensitive to light or very photophobic. So in this particular case, what I did was fit a contact lens that blocked out that side of the pupil, and very happy with the vision. But this could have been not been a problem had the surgeon been a little more aware of the patient's medications. Here's a good picture, and I put this in mainly just to show you what the crystalline lens looks like. Those little zonules are holding the lens in place. There are a few conditions where the lens of the eye slips out on its own, even in younger people, primarily like Marfan's type syndromes. But it's a good slide to show you what the lens looks like inside of the eye. Now, our older patients, before intraocular lenses were invented, simply had the crystalline lens removed and either have to wear strong glasses, very thick glasses, or a contact lens. And so their eye may look like that. That dark part that you see that runs from about 10 to 2 o'clock is where the incision was made, and that's just scarring. The pupil was cut like that to avoid glaucoma, and it's not a problem because we're holding the upper eyelid up, and then when that eyelid is in its normal position, vision is back down to normal. Now let's talk about the vitreous. The vitreous is a thick, transparent substance that fills the center of the eye. It is composed mainly of water and comprises about 2/3 of the eye's volume, giving it form and shape. The viscous properties of the vitreous allow the eye to return to normal shape if it's ever compressed or hit. So one of the most common complaints that we get is a patient will see that they say flashes and they see floaters in front of their eyes, sometimes all of a sudden. We have to rule out that this is not a retinal detachment. More likely it's called a posterior vitreous detachment. As we get older, the vitreous becomes more liquefied, and with time, it will drop down and detach. It's in a capsule, so when that capsule moves around, you see it as floaters, and as it tugs against the retina, you see it as flashes. In my clinical experience, it's very common for most people to have this between 60 and 65. If you're highly myopic, you have a little higher risk for it. If you're very active athletically, you might have this. But it needs to be investigated. If you see flashes or floaters, it's important for you to have a dilated eye exam to make sure that the retina has not become detached. Otherwise, we don't do anything about this and just explain it to the patient and tell them that you're going to see these flashes, and should you see part of your field of vision missing or more flashes, to get in immediately. Now, the vitreous can also have blood go into it. This is a patient that has diabetes, and you can see the bleeding inside of the eye, the inferior larger one, we call it a boat hemorrhage, and it's just bleeding, and it assumes that shape because of gravity. Now, this patient's probably not affected too much by vision, but in some cases the entire vitreous fills up with blood, and that has to be evacuated surgically in a procedure called a vitrectomy, which is done by a retinal surgeon. Now, we'll go back to the retina. This is what the normal retina looks like. The arrow on the left is pointing to the optic nerve. It's an annular configuration there. You see the blood vessels. The veins are the darker ones, the bigger ones. And then if you look to the right, that's the macula. That's an avascular area, and it has a dark appearance. That's where our visual acuity is the sharpest. That's where we have 20/20 vision. In fact, if we go just a few degrees off of that, the vision drops off significantly. Now, here's a patient that has high blood pressure. High blood pressure can damage blood vessels in the retina. The higher the blood pressure and the longer it has been high, the more severe the damage is likely to be. So in the picture on the left, you see how the blood vessels are all crooked and nicked. If we go back here, the blood vessels are nice shaped. They are a configuration that they should be. And then we go back, and then the bottom picture is where the hypertension has caused the blood vessel to block off and cause that excessive bleeding. And one of the complications here is a vision decrease and also glaucoma that's related to neovascularization. This is a patient that came in just before Christmas, noting in one eye that he had lost part of his field of vision. And when we looked at his retina, it was determined that he had plaques in there, probably cholesterol plaques from the carotid artery. The arrows are pointing to two of them that you see. Unfortunately, he will probably not regain any of that field of vision loss, but it's a medical emergency, and he was referred immediately to a cardiology clinic for a management. This is an unfortunate situation where the artery becomes occluded for one reason or the other, usually in older patients, and unfortunately they lose vision suddenly, and most of the time the vision does not come back. It used to be believed that lowering the eye pressure or breathing into bag would help this, but usually they've lost vision for good. Now, if a patient is complaining of headaches, the primary care doctor will always look at the optic nerve. That's to make sure that there's no pressure inside of the head, and if there is, the optic nerves will become swollen. In these cases, you see that you don't, in the right eye, you do not see the optic nerve margin clear. It's swollen. On the left eye, it's also swollen. It's a very serious consequence. This can be related to swelling in the brain from a mass or other conditions. Unfortunately, this is a common thing that we see in San Antonio routinely. We have a large population of diabetics in our city. The first stage of diabetic retinopathy is called non-proliferative. In other words, new blood vessels have not formed. But if you look closely at the eye, you'll see that there's scattered hemorrhaging, little bleeding there. Those white spots are fluid. And you can see that it's getting very close to the macula. And if the fluid gets in there, you have a vision problem. So these patients are followed closely. Now, diabetes can be a blinding condition. In this particular case, they probably didn't come in and get care, or they didn't take care of their diabetes. The picture on the left, the new blood vessels have completely detached the retina. So they have a tractional retinal detachment in the blind eye, and you can see in the picture on the right-hand side a lot of new blood vessels that have been formed because of the diabetes. So taking care of diabetes as related to other parts of the body, but especially the eye, are extremely important. The treatment for diabetic, which has been a godsend, is that lasers, the ophthalmologist will apply lasers around the peripheral part of the retina. And this reduces the stimulus for blood vessels to grow. And fortunately has given sight to many people, extended their vision for years. You can have cancer inside of the eyes. Every time you have your picture taken, you'll notice that people have the red eyes. Everybody should have a red reflex. That's because light bounces off the retina and comes back. If you should see a patient or a person that has a red reflex in one and a white in the other eye, it can be a cataract, but it can be more serious. It can be a tumor. So it's very important that these patients be examined immediately. Retinal detachments, fortunately, are not common, but they do happen. And they present as a flashing light, part of a field of vision missing. The photograph on the left indicates a retinal detachment in the superior hemisphere. And this patient wouldn't be able to see things down below in one eye. If it gets to that stage, it's not easy to repair. The other eye, the other slide shows one that's a little more peripheral. The problem is that a lot of patients don't come in when they have these symptoms, so you should encourage a patient that sees flashes, floaters, loss of vision, anything like that, to have their eyes examined immediately. Glaucoma is common with our older population. I've already discussed the angle closure glaucoma a little bit. The photograph on the left is a special lens, and with the photograph taken through this special lens placed on the cornea, that shows that angle. If that angle occludes, these patients build up pressures of 70 or 80 millimeters of mercury, become very sick, go to the emergency room, or vomiting, headache. And it's not for after a while that they determine that it's actually the eye that's causing these problems. So treatment is necessary with a laser and medications. Most of the people, though, have the chronic open-angle glaucoma. And this is a condition that doesn't have any symptoms initially. There's no pain, and the first thing that happens is patients may notice that they're losing their side vision a little bit. So routine eye examinations pick up conditions like this. And here you see that the optic nerve has what we call this large cup. Medications are very effective in lowering the eye pressure and preserving sight in patients with open-angle glaucoma that present early. This is an interesting case of optic atrophy where the nerve died. Our older patients are taking Viagra and these type of medications. This happened soon after a patient took Viagra. But by far the most common problem with our aging population is associated with macular degeneration. On the left is dry ARMD, and you see these little white spots are called drusen. The problem with macular degeneration, it usually causes these people to lose their independence. They cannot see things in the center vision. They cannot read well anymore. They certainly cannot drive. And you can tell that the photograph on the right-hand side is the wet type. So here you have bleeding, serious loss, very complicated course, and certainly we hope that you don't experience that. Well, that concludes my presentation. If you have any questions, I'd be glad to answer them. Thank you. Okay. So the question is, if you have a patient that doesn't respond, how do you know that they're actually having an eye problem or eye infection? In most cases, it's just visualization. If there's an eye infection, you're going to see a red eye, some distortion. Also, just the way they perceive their environment. If you move and they look at you, or you drop something they pick up, you know some idea of what their vision is. Their pupils should react. The eye should be white. The eye should look healthy. I hope that's what you're asking for. Here's a question from Maria. I missed the first few minutes, so I may have answered this question. My dad won't go to the doctor because he says that his eye issues are just old age. How can I urge him to go? That's an excellent question and a little bit hard to ask. I think that's one of the major problems, especially with males. They just assume that, that's just a part of the aging process. I would do anything I could to encourage the patient, just a routine eye examination, maybe some encouragement from the primary care physician, and some situations that, hey, this is going to get worse, and maybe we can treat something that you have. And here's a question regarding conjunctivitis. How could a conjunctiva get inflamed? The conjunctiva has blood vessels. So when these blood vessels are irritated either by allergy, by bacteria, or viral, they become swollen. The blood vessels dilate to bring blood to help the eye, and that's why you see the conjunctiva become inflamed. Here's a question. The floaters. As I understand, the floaters that I have caused are by age. Is there any way to reverse this, and are they really starting to bother? They are really starting to be bothering me more and more. That's a common complaint and a very good question. Unfortunately, there's not much to do with floaters, about floaters. If you have had your eyes examined, make sure that the eyes are dilated and that you did not have a retinal tear or retinal detachment, the surgery would be too serious to try to remove the floaters, so they're just left alone. Usually, fortunately, with time, people get used to them, or because of gravity, they will drop down to a lower level and move out of the line of sight. Particularly in my particular case, I have a right eye very big floater, and when I'm working, I'll tend to just move my eye around a little bit and just shake it out of the way. The most important thing is, though, that you should have had a dilated fundus exam to make sure that the retina is okay. Another infection problem, does an infection always hurt? No, usually not. If you have the infection, there may be a little burning, a little bit of itching. The thing that you have to worry about is that it may be contagious. So you shouldn't share towels, washcloths, things like this. Usually not much pain associated with conjunctivitis unless the cornea is involved. And if the cornea is involved, that needs to be looked at by an eye doctor to make sure that there's not a more serious problem there. Well, thank you for your attention and your questions.